United States has been living a major health crisis, approaching 1 million overdose deaths over the past 20 years. People of color use and sell drugs at lower rates than white people, and yet they face much more severe consequences of substance use, including death, incarceration, and illness. I'm a social worker and an expert on substance use disorders and health equity. Reflecting over my personal and professional experiences, I grew frustrated with the American healthcare system that treats substance use disorders as an individual problem, despite evidence that social determinants of health, such as poverty and discrimination, play a significant role. I have learned that if we are to truly heal substance use disorders, we must adopt multi-level solutions that integrate a biopsychosocial approach informed by trauma, history, context, social justice, and compassion. I believe that social workers are well poised to lead the way given our training in social justice. I would like to invite you to join us in dialogue through a webinar series sponsored by the Council on Social Work Education and funded by the Substance Abuse and Mental Health Services Administration. Our goal is to get together and reimagine the field of substance use disorder treatment through innovative social work education, practice, and research. Will you join us?
Welcome, everyone. My name is Lily Windsor. I am Associate Dean for Research and Professor of Social Work at the University of Illinois at Urbana-Champaign. I conduct community-based participatory research to promote health equity in the fields of substance use disorder, infectious disease, and involvement in the criminal legal system. I am honored to be moderating the CSWE webinar series today. I would like to thank CSWE for putting the series together, and I would also like to thank Joseph Bass, Javier Coblera, and Crystal Pegues for assisting in the development and implementation of this series. Today, we have two wonderful and well-known high-caliber speakers with a great deal of experience advocating for better mental health and substance use disorders policies in the United States. It is my pleasure to welcome Dr. Ron Manderscheid and Ms. Deborah Steinberg as our third webinar presenters. Dr. Manderscheid is principal at Capstone Solution Consulting Group, an adjunct professor at the School of Public Health at Johns Hopkins and the School of Social Work at the University of Southern California. He has served in numerous leadership positions. To highlight a few, since there are too many to list here, he was a member of the Department of Health and Human Services Secretary Advisory Committee on Healthy People 2020, the Clinton Healthcare Reform Task Force, and president of the National Association for Rural Mental Health. He also serves on the board of the American Academy of Social Work and Social Welfare. Dr. Manderscheid has a prolific publication record with over 550 papers on services to persons living with mental disorders. Ms. Steinberg is a senior health policy attorney at the Legal Action Center who advocates for state and federal policies to expand access to comprehensive and equitable substance use disorder and mental health care. She seeks to eliminate discriminatory barriers to treatment in Medicaid and private insurance and assists the states in improving their enforcement of the Mental Health Parity and Addiction Equity Act. Ms. Steinberg also co-leads the Medicare Addiction Parity Project, an initiative to expand Medicare's coverage of substance use disorder treatment and apply the Parity Act to Medicare. In this role, she drafts legislation and regulatory comments, facilitates coalitions, and educates the community at national and local presentations. She has a BA in psychology from Vassar College and earned her JD from Georgetown University Law Center. Today, Dr. Manderscheid will start by providing key background information on drug use and care in the US. And this will include prevalence of substance use disorders, prevalence of treatment, the relationship of COVID-19, opioid use and depression, and the full range of interventions to address opioid use. Ms. Steinberg will follow with a case study of one current substance use disorder policy challenge, the lack of sufficient substance use disorder coverage under Medicare the federal insurance program for older adults and people with disabilities. She will highlight the existing treatment gaps, policy opportunities to ameliorate these barriers, in ways that social workers can engage in this policy advocacy. But before we start, I want to cover a few housekeeping issues. First, I am the CSWE lead consultant in substance use disorders for the year. So if you have questions on this topic, feel free to email me and I can point you to the right direction. We have a large audience, so if during the presentation you have questions and comments, please post them on the chat. We will reserve about 30 minutes at the end for questions and discussion. I will be reading the questions and comments so that Dr. Manderscheid and Dr. Steinberg can respond. We may not get to all questions, but I will try my best. So with no further ado, let's go ahead and get started. Dr. Manderscheid, please take it away.
Okay, so we're good here. So thank you very much for inviting me today. I'm always delighted to do this and honored to do it. I know that a number of you who are participating today have a family member or a friend, a coworker, a neighbor, a child, a parent, an aunt, an uncle, a grandparent who has been involved in drugs. And you're partly here to learn what's going on in the field, but you're also partly here to help your friend or your relative. So I want you to know, even before we start here, that we have not forgotten you and we are working on this issue. Two, treatment does work and recovery does happen. And so if you get nothing out of this webinar other than that idea that treatment does work and recovery does happen, and that you can help your family member, your friend, your coworker, your neighbor to address this problem, this will all have been greatly worthwhile. So start with that, and I'll probably end with that. So what I want to show you first here is a little bit of data on drug use in the United States. This is very recent data. Most of this data is from 2021 or later, basically. So if you start with the broadest category, any use in drug over the course of a lifetime, it involves half of the adult population of the United States. 138.5 million people have used drugs in their lifetime, either illegal drugs or have done misuse of prescription drugs. In the last year, that goes down to about a quarter of the population, not a little less than a quarter. 59.3 million have used these drugs in the last year. 37.3 million, or 13%, have used in the last 30 days. 9.5 million are people who have ended up as a result of this with drug use disorders, which is about 3.4% of our adult population. And 2.3 million, or about 1% of our adult population, actually have an opioid disorder. And then the most recent data on deaths from drug overdoses, about 107,000 people died in 2021. Those numbers are just dramatic increases from what we've seen in the past. If you go back just a couple of years, we were talking about 70,000 people a year. It jumped by 30% in 1 year, and I'm going to attribute a lot of that jump to what happened as a result of COVID. So the basic point of all of this data is we have a very broad-ranging problem of drug use and abuse in the United States. And I think we have to look not only at this problem, but have to ask ourselves the question, why do we have this particular problem in the United States, and what can we do about it? If I look on the other side here, on care received, we're really not doing very well on care received. Only 14% of people who've used drugs in the last year actually receive care currently. And I remember just a few years ago, that number was 10%. The Affordable Care Act has helped us move the needle, that 4%. But that's not nearly enough, not nearly enough. And there are new resources going into this problem through the American Recovery Act, and more recent legislation and the recent appropriations bills for fiscal 22 and fiscal 23. If I look for people in lifetime, what percentage of people who've used drugs in a lifetime have received care? Only a quarter have received care. So 3/4 of the people who've ever used drugs never receive any care in the United States. So those numbers on care are really pretty tragic. And again, we need to be paying attention to those numbers, and we need to be, vastly improving them. I know there are many, many national organizations who work in the drug use space, who are working every day with the Congress on these issues. I was involved for many years in the Coalition for Whole Health that represents currently about 265 mental health and substance use organizations that meet monthly and do a lot of work with the Hill to try to move this agenda on improving our care for people who have drug use issues, basically. Me go ahead. I want to go ahead then and talk a little bit about what I call the twindemic and its consequences. So I said before that the situation got much worse after April 2020 as a result of COVID-19. And there are several linkages here that basically have led us into this problem. So we know factually through research that's been done that COVID-19 greatly increases the probability that a person will develop a disorder such as depression. And probably 30% of the people who actually had COVID also developed depression symptoms at some point or another. And makes perfect sense because when you talk about COVID-19 and you talk about long COVID, you are talking about changes to the brain that have occurred as a result of COVID. And those changes occur in the central nervous system of the brain and lead to depression, which is affected by how the opioids are uptaken or not uptaken in the brain, et cetera, et cetera, et cetera. So we know COVID-19 relates to depression very closely. We also know that depression relates to opioid use very closely. And I can go in this model either way. One direction would be to say, if you have COVID-19, I'm going to predict that the probability is going to go up dramatically that you will develop depression. If you develop depression, the probability triples that you'll also be engaged in opioid use within 90 days. The same is true in reverse. If you get COVID-19 and you start using opioids, the probability goes up by 2.5 times that you'll develop depression. So there's a kind of a co-equal relationship here between opioid use and depression in relationship to COVID-19. And we need to keep that in mind because even though COVID-19 has abated, if people have been exposed to COVID-19 and now have what's called long COVID, they are at risk of both of these things happening. They're at risk of depression, and they're also at risk of opioid use. We also know that both depression and opioid use relate to other chronic diseases that people develop. And if left untreated, they can result in death easily. It can result in death through an opioid overdose. They can result in death through a suicide, et cetera, et cetera. So these things are very, very closely related, and we need to pay attention to that in a way that we did not need to previously. So what is it about COVID-19 that has led to these relationships? I think, and every one of you who is on this webinar today, I'm sure had experiences in your own family and in your own workplace where everything in your life changed dramatically on about the 15th of March of 2020. Your children stopped going to school. They were basically homeschooled by a video with the school. You stopped going to work and you worked at home using Zoom and other tools. You became the carer for other people in your family, an elderly person or a disabled person, and so on. And we lost a lot of the components of our life that are important in terms of personal well-being and community well-being. And the longer this went on, the more this resulted in problems in families, the more this resulted in mental health problems in families, the more this resulted in substance use problems in families, and so on. So that's kind of the sociological side of COVID-19. That relates also to the other side that I just talked about, which is, I would say, is the brain side of COVID-19, that relates directly to opioid use and depression. So that's the context of the problem at the present time as we begin to move out of COVID. So I want to go on then and talk a little bit about what do we need to do about this problem. And obviously, the very best treatment here is to not need treatment in the first place, but to prevent these things from happening in the first place. So how can I prevent this diagram that I'm showing you from actually playing out the way it's written here? What needs to happen? And Lily started this, she said a little bit about this in her introduction. On the front end here, we absolutely have to spend more effort and time working on the social and physical determinants of health and of life. What are the things in people's lives that are negative that lead them to have trauma, and as a result of the trauma, to develop depression, to develop opioid use or other drug use, and so on? What are those things in life? It could be things like racism. It could be things like, poverty. It could be things like exclusion from the community. There are a whole host of, it could be poor housing conditions, living with rats. There are numerous social and physical determinants of health that can lead to trauma, that can lead to the development of behavioral health conditions. And we have a huge agenda as a field going forward, actually to work on these social and physical determinants of health. And I've been doing some writing about this most recently. As if we're going to begin working on these things, we need to develop good and close relationships with our colleagues in public health. They know how to do community-wide interventions. They have not only the knowledge of the strategy of how to do this, they have the tools to do this. They know how to do things such as population health management and other things by which we can begin to disaggregate these social and physical determinants of health that lead to trauma, and to begin to address them and begin to identify through predictive analytics people who are most likely to be affected by them, so we can work most closely with those people. Very, very important piece of our work, and something that all of us who work in the behavioral health field need to be pushing. The whole issue of racism is very important here as well, because racism in and of itself is a very negative social and physical determinant of health. And, the strongest thing I can say about racism, if you are exposed to racism in a significant way, I can predict with very good accuracy that this is going to take years off your life. And the prediction is you will lose anywhere from 7 to 11 years off of your life as a result of racism being expressed against you. That's a terrible number, actually, if you think about it. So if you're in that context where you are exposed either to direct interpersonal racism or structural racism, then you're at risk of all these things we're talking about here. You're at risk of opioid use, you're at risk of depression or other behavioral health, anxiety, other behavioral health conditions, and so on. We need to pay close attention to that. Another factor here, and I can only spend a couple minutes on it, but I want to introduce the idea. In my opinion, I've been writing about this recently as well. I don't think our communities as communities function very well. And over time, I think our communities are receding. We're spending less and less time in our communities. We're spending more and more time of our life in social media. All of these things, we're kind of withdrawing. So if I look at, how a house is built today versus how a house would be built 50 years ago. 50 years ago, the house would have been built with a porch on the front side looking out to the street. Now a house would be built with a porch or a deck on the back of the house looking into the backyard. We've become inward looking rather than outward looking. We've become less engaged with other people, not only people, in our workplace. We probably don't have as many friends in the workplace, but also people in our neighborhoods and so on. So our communities are not functioning as well as they might. So there's a lot of work going on to say, what can we do to actually reinvigorate or invigorate, because they haven't been read here, with our communities to move the agenda on this issue. And some very interesting work in the US and also in some other countries. That work typically involves looking at things such as, how can we put together some efforts to create a self-empowered community? And there are some basic principles in that work. I want to quickly go over here to point them out. The first principle is you've got to listen to the community. The people in the community know best about what's going on there. They know best about what the problems are in that community. And they also, in the long run, can be the best advisors in helping design solutions to those problems. So it's critical to listen to the community. Another principle here is the principle of exclusion, that every community has historically excluded groups. In some cases, they will be racial minorities. In some cases, they will be groups, the elderly are excluded. In some communities, it will be a religious group is excluded. And so every community has historically excluded groups. Those groups absolutely have to be brought into the dialogue if you're going to be successful at this work. The third principle, it's absolutely critical to engage Indigenous leaders in that community. There are Indigenous leaders in every community. We need to identify those people and work with them, because they can be very, very helpful in developing the community structure and engaging people. And finally, the fourth principle here, when you do self-empowering work in communities, it's absolutely important to have community-wide celebratory events, dinners, dances, all of these things where people come together and it becomes centripetal space rather than centrifugal space. So the Hogg Foundation in the United States has been doing work in a number of counties in Texas. That's excellent work. You can go to the Hogg Foundation website. And there are also projects ongoing in Canada, in New Zealand, Australia, and the Netherlands, working on the same issues. And what's very interesting in this work is they all pretty much come to these same principles that I just went over. With better functioning communities, you have outreach to people in the community who are experiencing difficulties. And that in and of itself can become a factor in reducing the risk of those people for depression and opioid use in the way that I'm talking about it here. So what I'm trying to get at in this block of items here is, what are the things that can be done upstream to prevent someone from developing a drug use problem or depression before it ever happens? Now, moving downstream, what do we need to do for people who have opioid use problems or depression? we need to have integrated treatment. By integrated treatment, I mean we have to look at the whole person. It has to be person-centered care. Person-centered care that involves not only mental health care and substance use care, but also primary care. Many of the people we're talking about have chronic physical conditions as well as opioid use or depression. All of these things are part of a package, and we need to treat them as such, and we need to set up our integrated treatment systems. So I've been working on integrated treatment for a very long time, and I would say we successfully established the idea of integrated treatment in the Affordable Care Act of 2010. In 2014, when that became implemented, we started with a number of programs. For example, there was a program in Medicaid to provide awards to states for states to actually develop integrated treatment sites, accountable care organizations, and so on. That began to happen, but it didn't happen in a very strong way. And people who work in the behavioral health space, I think, were very frightened of integrated care. They had two fears. One, they were going to not have a career anymore. All the work that they were doing would be taken away, and or their own organization would disappear into another organization. When I used to go out and give talks about this, I couldn't talk about the substance of integrated care till I addressed their fears, because they wouldn't be hearing anything I was saying. So that it's obvious that's not true. None of those people have been, put out of work because we have been doing integrated care. And most of their organizations, even if they did change, have been integrated into bigger organizations. The organizations, in effect, are still there. So those fears did not prove to be true. However, that greatly slowed down the implementation of integrated treatment that we need. And what has helped it in very recent times, and back to COVID-19 again, in the month of April 2020, beginning of the month, we were pretty much as a field where care was provided interpersonally. At the end of the month, we were pretty much a field where care was being provided virtually, either over the telephone or over a system such as the one we're using here today. That has made it much easier for integrated care to actually occur if you don't have to go through all the bells and whistles of integrating organizations, et cetera, et cetera. And I've had a number of students at USC who actually had projects in this area. One that I'm recalling right now, a student from Boston, who worked with psychiatrists at Mass General Hospital and primary care physicians in Western Massachusetts, where they developed an integrated treatment system. When someone would come into one of the primary care offices in Western Massachusetts with behavioral health symptoms, the primary care physician would contact the psychiatrist at Mass General, who would then work with that client at the same time that the primary care provider was there. And that system worked reasonably well. Well, that model is pretty much the model we have been developing over the last several years, where with virtuality, we have been able to expand integrated treatment. One other feature of virtuality I want to mention here is the fact that I believe, and I think the data will support this, that with virtuality, we've changed the relationship between a provider and a consumer. In our traditional interpersonal model, the consumer typically went to the office of the provider. Well, in that relationship, that is an unequal relationship. I, the consumer, am coming into the provider space. The provider is in control of the space, and in a certain sense is in control of me, the consumer. Virtuality equalizes the relationship between the provider and the consumer. And that virtuality has made it much easier for some people to actually participate in care, and some people actually do much better in a virtual care environment than they do in an interpersonal care environment. That's not to say that there are other people who would not do better in a interpersonal environment, but we need to begin distinguishing who does better in which type of environment, and then trying to get people more into those environments where they actually do better. So I think those are all features that we have to look at as we think about how are we going to intervene in these problems once they have occurred. So I think integrated treatment done well, and we need to consider virtuality in this so we can reach more people at a distance, et cetera, et cetera, et cetera. Then also my third step here, offering support. We aren't done with our work here simply when someone has received some form of care or treatment. A huge part of being successful in this work and getting the person to recovery is, how do I, in effect, help integrate or reintegrate that person back into the community so that they have a social support network, so that they have a job, so that they have a place to live. And what do I need to do with them to help them on their personal journey of recovery? These are all absolutely critical steps here. Even as the treatment process ends, if we don't do these steps, then I think we're, again, wasting a lot of the treatment money, because we won't be successful if we don't integrate the person back into the community. So I want to make that an important part of what I'm talking about as well here. So I have a couple other points. I'm watching the clock here, and I'm stop in a couple minutes. So a few topics to add that I think relate to this whole model. We need to eliminate stigma and bias around drug treatment. We need to eliminate stigma and bias around drug treatment. What are some of the things that are involved here? It's very important, for example, that fentanyl strips be available. So if people are using opioids, they're not using opioids that have fentanyl in that will kill them. It's a life or death matter. Not every geographic area permits fentanyl strips. Very, very important. It's absolutely critical that naloxone be as broadly available as possible everywhere. Everywhere. It should be not only in hospitals and doctors' offices, it should be in police cars, it should be in EMS vehicles, it should be in people's homes. Naloxone is absolutely critical in saving someone who is having an opioid overdose, basically. Harm reduction programs, needle exchanges, sites for drug use under controlled conditions. We need to be developing these programs for the US here in various ways. And finally, and I think it's doing better now than it was doing before, medication-assisted treatment. Medication-assisted treatment can be a lifesaver for people who actually have overdose problems. My second area I want to spend just a second on, part of this whole model that I'm talking about, all the way from upstream in the transform down to provision of care to community support, we need peers to work with us to help us do these things. We don't have nearly enough providers. There are thousands and tens of thousands of peers out there who are prepared and want to work with us in helping other people address these issues. And we need to engage these peers. We need to pay them a decent salary to work with us on these problems and so on. So they are an absolutely critical part of what we need to do. And then my final third point, which is what I went into before, we need to be very much engaged in rebuilding our social network in the United States. And my final comment, if you haven't seen it, I encourage that you read the Surgeon General Murthy's recent advisory on the epidemic of loneliness and social isolation in the United States and the consequences of that epidemic for our health and behavioral health, and his recommendations for how we begin turning that around. I personally believe that that is a huge part of what we're experiencing, part of the reason we experience such broad-based drug use in the United States is because we've lost our ability to relate in our communities. So with that, I'm going to say my time is up and I'm going to stop. And thank you very much for listening to me. I'll take down my screen here.
Hi there. Thank you so much, Ron, and thank you everyone here for having me. I really appreciate the opportunity. As Lily said, my name is Deb Steinberg, and I'm an attorney with the Legal Action Center. Let's see. All right. So today I'm going to talk to you a little bit about one way that folks have been trying to improve access to substance use disorder treatment, and that is in Medicare. I'm going to talk about the prevalence of substance use disorder in Medicare, some policy proposals to improve Medicare's coverage, and how social workers, whether you're a student, a faculty member, or a practitioner, or working on social work in the community, how you can and do help with these efforts. So first, Medicare and substance use disorder. Medicare is the federal insurance program for people over age 65 or 65 and over, and it also includes people who are under 65 who have chronic disabilities. It covers about 64 million Americans. It has different parts, which makes it a little bit more complicated. You have to enroll in your hospital insurance separately from your medical insurance, and separate from that is your prescription drug coverage. Some people are enrolled in managed care for Medicare. That's called Medicare Advantage. That's when you have a private insurance company managing your Part A and Part B, so your hospital and your medical insurance together. Sometimes it also covers Part C, Part D. It's complicated. I know that. I'm not going to go too much into it, but you can also be enrolled in private insurance or Medicaid, sometimes supplemental Medigap plans at the same time, because Medicare is expensive. It's not free. You're paying into it. And a lot of people still can't afford treatment when they're enrolled in Medicare. Among Medicare beneficiaries, so these 64 million Americans, approximately 9% had a substance use disorder in 2021. So that's about 4.3 million individuals ages 65 and over. And we've talked a lot about opioid use disorder. There's a growing number of folks who have an opioid use disorder in Medicare, but still the primary substance use disorder is alcohol use disorder. But we're focusing on opioid use disorder and opioids a lot right now because there's an opioid public health emergency. So just like we declared COVID-19 a public health emergency, we've had this opioid public health emergency for a number of years now because it is a problem that has caused, as Ron said, over 100,000 deaths. And in Medicare alone, we had over 50,000 Part D beneficiaries experiencing an overdose in 2021. And again, access to treatment is really, really bad. In 2019, only 11% of Medicare beneficiaries with a substance use disorder received treatment. And this rate is worse among those in the Medicare program who are age 65 and over. It was only 6%. And a lot of these folks are reporting that cost is one of the primary barriers to treatment. 38% of Medicare beneficiaries age 65 and over did not receive needed treatment because of financial barriers. And this plays out because we see that folks who receive subsidies for their Medicare actually have higher access to medications for opioid use disorder. But still, fewer than 1 in 5 Medicare beneficiaries with an opioid use disorder received medications for their opioid use disorder, which is one of the gold standards of treatment. This is also a racial justice and equity issue. Black men ages 65 and over are 7 times more likely to die of an overdose than white men over age 65. And again, access to medications for opioid use disorder is also very inequitable. About 17% of white beneficiaries were getting treatment for their opioid use disorder with medications. It was only about 13% for Black beneficiaries, 12% for Hispanic, and 10% for Asian Pacific Islander beneficiaries. Age is another area where we see disparities. Only 8% of Medicare beneficiaries ages 65 and over with an opioid use disorder receive medications, compared to 25% for those under age 65. So what does this mean? We've heard from people that they lose access to treatment when they turn 65 or when they become eligible for Medicare. One social worker who we've been working with shared with us that every week as their client was getting closer and closer to becoming eligible for Medicare, he asked his therapist every week, do I still have to transition to Medicare? I don't want to lose all of my support. So this is because Medicare's coverage is really, really bad compared to what we see in other insurance types. So Medicare does not cover the full continuum of care. We look at substance use disorder on a continuum, just like we do with other chronic conditions. There's low intensity level of care, medium intensity, and high intensity. Medicare covers low intensity pretty well. It covers screening, it covers some outpatient care, and it covers the high intensity. It covers inpatient care in a hospital, but it doesn't cover the intermediate levels of care. It does not cover residential treatment, for example. And starting in 2024 will be the first year that Medicare covers intensive outpatient treatment. So that missing gap in the middle prevents people from stepping up to a higher level of care they need if you need more than one outpatient visit a week. And it prevents people from stepping down safely into their community. You can't just be discharged from the hospital and be expected to be fine. There are lots of steps that we need in between there, but you can't get coverage through Medicare for that. Medicare also isn't covering crisis services, and it's not covering contingency management, which is one form of treatment that is motivational interviewing combined with incentives. And it's one of the only effective treatment modalities for stimulant use disorder. So again, right now, we're really missing the mark on how we need to be treating people based on what is happening in the community, how services are actually delivered, and what are really the evidence-based practices. There's evidence that this treatment works. Medicare also doesn't cover all of the providers and settings that are in the community and that are able to treat folks. So Medicare doesn't cover licensed and certified addiction counselors, doesn't cover peers, doesn't cover freestanding substance use disorder treatment facilities. So that's a lot of the places where people actually go to receive care. Another problem is that there are discriminatory reimbursement rates baked into Medicare. So for example, licensed clinical social workers are reimbursed at 75% of what a physician is reimbursed, compared to non-physician medical practitioners like physician assistants who are reimbursed at 85% of the physician rate. So it's not really sustainable right now for a lot of folks to be practicing in Medicare. And that is a problem in statute. That is something that needs policy change. Another problem, Medicare is not subject to the Mental Health Parity and Addiction Equity Act. This is a law that has been in place since 2008 for Medicaid and private insurance that says your insurance company has to treat people with mental health and substance use disorders in a way that is comparable to how they treat people with medical and surgical conditions. So if your insurance company offers unlimited physical therapy visits, they can't restrict you to only 10 mental health therapy visits in a year. And if your insurance company allows everyone who's a physician to join their network, then they can't say, oh no, we have too many social workers in our network, we're going to reject you. These types of things are illegal in Medicaid and private insurance, and they are still allowed to happen in Medicare because Medicare is not subject to this critical anti-discrimination law. There are also really burdensome and restrictive utilization management practices, prior authorizations, getting permission from the insurance company to give treatment. This is a huge problem that prevents people from getting timely access to care. There are step therapy requirements, such as requiring someone to fail first at one form of treatment before trying another. And they use overly restrictive medical necessity criteria, like saying you have to be in an acute state of your substance use disorder condition before being able to get treatment, whereas we don't have that same kind of restriction for medical conditions. There are severely inadequate networks of substance use disorder providers and a shortage of culturally and linguistically effective providers. Another issue is that Medicare has this weird custody exclusion. In both Medicaid and private insurance, they can't provide coverage for you or cover your treatment while you're behind the walls if you're incarcerated. But the Medicare custody exclusion goes a little bit further. It also considers you to be in custody if you're on bail or parole or even like medical supervised leave. So these folks who are eligible for Medicare are not able to get any of their treatment covered, even though they're in the community and not actually receiving treatment behind the walls. So this is a huge problem that millions of people in our country are not able to get the substance use disorder treatment that they need, but there are policy solutions to these barriers. So the first and most important one is applying the Parity Act to Medicare, applying this anti-discrimination law to Medicare. We need to make sure that we recognize that when you turn 65, when you have a disability, you have non-discriminatory access to treatment. Applying the Parity Act to Medicare would eliminate some of the discriminatory quantitative limitations in Medicare. For example, there's a 190-day lifetime limit on inpatient psychiatric care that does not apply to inpatient medical care. It would improve access to providers because it would require reimbursement rates to be equitable. They couldn't reimburse at 75% when other providers at the same skill level are getting reimbursed at 85%. And it would require Medicare Advantage plans or those private insurance plans to use comparable policies and practices when admitting providers who are treating people with mental health and substance use disorders into their networks. It would improve access to care by making sure that some of those utilization management practices I mentioned before cannot be applied more stringently or more restrictively for people with mental health and substance use disorder conditions than they are for people with medical and surgical conditions. We can also take action in statute to eliminate some of these specific concrete barriers. We can require Medicare to cover the full continuum of substance use disorder treatment, residential treatment, crisis services, contingency management, as well as recovery supports and services, as well as harm reduction. These are things that we can legislate to be included and covered in Medicare so that people have access to it. We're going to require Medicare to cover the community-based substance use disorder treatment facilities and the full range of provider types that make up the addiction treatment workforce. And we can require Medicare to reimburse these providers, including social workers, at sufficient and non-discriminatory rates and ensure that they can practice in all of the settings where they deliver care. For example, right now, there's a limitation that prevents social workers from being reimbursed in skilled nursing facilities, but we know there are social workers there and that they're treating folks with substance use disorders and mental health conditions. Not everything is through Congress. There's also a lot of stuff we can do with the Centers for Medicare and Medicaid Services. That's the federal agency that oversees Medicare and that ensures that the laws are being implemented effectively. But they have flexibility, they have leniency. So we can build out some of those intermediate levels of care to make sure that they are inclusive of patients with a substance use disorder diagnosis. Right now, the way those benefits are written is they're really geared towards people with mental health conditions, and they're not covering substance use disorder counseling as one example. We can continue to make advocating to make telehealth flexibilities permanent. We've gotten pretty far here, but we need to expand it while also making sure that people still have access to in-person care and that they have a choice, because we know that while some people prefer telehealth, it's not for everyone. We can also require Medicare Advantage plans, again, those private insurance companies, to have networks that are adequate, that are sufficient to meet folks' needs, and that they report on who is in their network, that they're actually reporting on their substance use disorder providers. Right now, there are no specialty types in Medicare where they have to report that are for substance use disorder, but they have it for most other types of conditions. Again, CMS could independently take action to eliminate discriminatory utilization management practices, such as, eliminating all prior authorizations for medications for opioid use disorder. We think that would be one key way that would improve access to care. Expanding access to harm reduction and integrated care for Medicare beneficiaries, and eliminating the custody exclusion for beneficiaries in the community. And also, all of this is really important because folks who have Medicaid and private insurance, where they're supposed to be protected by this anti-discrimination law, a lot of those plans actually use Medicare as their baseline when they decide on their policies. They look to Medicare reimbursement rates when they decide what reimbursement rates they set. But if they're doing that, they're actually baking in these discriminatory practices, and we're allowing that to bleed into these other systems. So we're exacerbating the problem for all people who have insurance that should be subject to the Parity Act when we allow Medicare to continue to be implemented in this discriminatory way. And I talk about insurance because these are health conditions. Substance use disorders and mental health, they are health conditions. When you get health insurance, you expect that your treatment will be covered. And what we're seeing right now is that it's not. And there are grants, there are other things that we do to supplement the problem, to put a Band-Aid on it. But ultimately, if we want to truly integrate substance use disorders and mental health conditions, we have to get it meaningfully and comprehensively covered by insurance, especially in Medicare, because of these consequences that it has for other insurance types. So how can social workers help, and how are they already helping? So my brief primer on advocacy, because advocacy often sounds like a really scary word. Advocacy is really just sharing stories and/or data with policymakers. It is telling the policymakers what the problem is and what your solution is. I just did all of that in this presentation. You could repeat what I just said, or you can share your own experiences. Sometimes those stories are even more meaningful, because when you tell your Congress member that you cannot treat people, or that the people in your community can't get the care that they need, like your mother, your sister, your friend, anyone, that lets the congressperson know that it's their constituents that are hurting here. And sometimes that goes even further than data. It's different for everyone. So having each of these tools in our tool belt is what allows us to make successful policy change. So if you're a practitioner, you can share your story. You can do that directly with us. We've made it even easier than talking to your Congress member if that scares you. Have you had trouble finding treatment programs or referrals for Medicare patients? Are you unable to treat Medicare patients because the reimbursement rate is too low? Is the paperwork too burdensome? These are the types of things that are actually, again, resolvable with the Parity Act. And so collecting these stories is what allows us to make a compelling case to Congress that these changes are needed. We're hoping to publish an issue brief soon talking about some of these stories, totally de-identified. So if you feel comfortable sharing your story with us, again, that will allow us to make meaningful change across the country. You can contact your legislators directly. I know it sounds scary, but it's often not. You're usually talking to someone who is probably just like you. They're trying to make a difference. So you can find your elected officials, you can call, you can email, you can write a letter, you can send a message on their website, and you can really be short and sweet. You can just tell them what the problem is and why it matters to you. And if there's legislation that you support, and there's plenty of pending legislation that affects social workers in Medicare, then you must do that. You must tell them that you want social workers to be reimbursed at an adequate rate. You must tell them that social workers need to be able to practice in skilled nursing facilities. You must tell them that we need parity in Medicare. And again, you can be short and sweet, because the person who's answering the phone is sometimes just tallying who supports it and who doesn't. So it's not a hard lift, but even easier than that, you can sign up for action alerts from organizations, and they often will provide you with a script or a template telling you, here's exactly what you say, or they'll write the whole email for you and you just click send. And all of these are ways that you can get involved in policy and make sure that your voice is counted. Because oftentimes there are people who are making the opposite argument, and their voices can be loud. They are saying they don't want people getting substance use disorder treatment in their community because of the stigma, because of all of the problems that we know exist in the world. So you need to be the voice on behalf of these people. Another way that you can get involved is submitting comments on proposed regulations. CMS, again, the agency that oversees Medicare, puts out regulations every year saying what the fee schedule is, how much they're going to pay folks. They ask for, how should they be addressing social determinants of health? You can respond to these comments. You don't have to be a lawyer, and you don't have to be a professor. You can be anyone to respond to these comments. And again, there are people making the opposite argument, so you need to speak up when you can. Here are some references. Always happy to go into more detail. Talking about this is important. We have to shed light on these issues. But really just thank you so much for letting me be here and for sharing this information with you. I hope you will get involved in advocacy, whether it's on the Medicare issue or others, but really believe that there are policy changes that can make a difference for people with substance use disorders. And as social workers, students, professors, practitioners, you can all be involved in helping us fix these problems. So thank you, and we're really happy to take questions.
Thank you, both of you. And amazingly, we are right on the time. So thank you for that. I really appreciate such an enlightening presentation. Dr. Manderscheid, I love that you centered social determinants of health and prevention to address substance use disorders in the US. I agree wholeheartedly with you on the importance to engage communities, integrate care, hire peers, and help provide services, collaboration across professions, and the importance of addressing the impact of racism and stigma as absolutely critical strategies in combating substance use disorders in the U.S. And Ms. Steinberg, the low rates of the substance use disorder treatments in the U.S. are absolutely unacceptable, and the example of how this works in Medicare is very helpful to illustrate the inequities, as well as some of the reasons that we have such low treatment rates. But more importantly, I think it also helps illustrate the power of policy as a tool to address these challenges, right? With the stroke of a pen, you literally change the lives of millions of people. And I think that sometimes we get really involved with our day-to-day practices and things, and we forget the amazing power of policy, both at the federal and the state levels. So just today, I submitted a letter to my representatives on the fentanyl legislation that is going through the House right now. I was not one to do much of that until a few years when I actually went to the Hill and spent some time there trying to learn more about health policy and realize that it really makes a difference and how important it is for us to use our voice. I would like to stop here for a minute and encourage the audience to start posting your questions on the chat. I'm going to be going through them and then sharing them with the presenters so that we can get into the Q&A. But before we do that, I would like to take a little bit of time to hear some remarks from Dr. Kalavalu Vakalalahi, the president of CSWE. So if we can go on to the video, hopefully we'll have sound.
Aloha, my name is Halaivalu Vakalahi, President and CEO of the Council on Social Work Education. Thank you for joining us today. Our 4-part webinar series on reimagining substance use disorder interventions to reflect social work values is part of our commitment to CSWE's mission to advance excellence and innovation through quality and relevant social work education. We hope that this webinar series will benefit you, your colleagues, students, faculty, and staff, and your community partners. Please take advantage of the continuing education credit available on demand, free of charge. Making this webinar series possible, we want to extend our special thank you to our partners at the Substance Abuse and Mental Health Services Administration, specifically the Opioid State Targeted Response Technical Assistance Grant. Again, thank you for joining us today. Until we meet again, be well.
Okay, great. So I'm gonna go back into the Q&A. We talked a little bit about the importance, right, so of policy and the power of policy in changing people's lives. Unfortunately, social work as a profession has not been very effective in advocating for our clients at a policy level, especially in comparison to other professions. So can both of you talk a little bit about why this has been the case historically, perhaps, and how we can get better at doing that? What are some of the efforts that are happening right now to try to increase our efficacy and advocacy?
So maybe start and give a little overview, and Deb can add to that. So I think historically, social work, when it was founded, was very much a practice and advocacy activity. It didn't start as an academic exercise. It started as an exercise in the community, getting housing for people who did not have housing, improving some of the inner city areas in the United States, and so on. So it had very much an action mission that was right out there. It was engaged in policy and practice and so on. Then I think social work went through a change where social work, to become academically respectable, needed to develop its own specialized knowledge and its own specialized research. So it took it away from that practice and moved it into the academy, where it's been, I think, pretty much for the last 40 to 50 years. And because of that, I think currently the field has relatively few people who are out in practice. Most of the people I know in social work are in the academy. The people who are working out in the field, who are social workers, are working as clinicians. They are not per se functioning as social workers, and there would be a distinction. We can talk about that if people are interested. So I think there's a huge agenda of engaging these people in the academy back into the world of policy. For example, at USC, one of the things that we did in training of the doctoral students is every doctoral student spent a week in DC. Part of their project, working on one of the 12 grand challenges, was to actually go to the Hill and advocate for the solution they were proposing in their grand challenge to the appropriate people on the Hill. They actually had to go and set up a meeting, do the meeting, debrief from the meeting, et cetera, et cetera. So I think part of this is engaging more people in this. I personally have also worked with actually the Council on Social Work Education and the National Association of Social Workers and SWER, the Society for Social Work and Research, in trying to identify people from the academy who would be willing to come to DC and become more engaged in these things, become engaged in serving on a commission, become engaged in serving on an advisory group, becoming engaged in giving testimony on the Hill, and so on. So if there are any people on this webinar today who have interest in that, please be in contact and we will see that you get engaged in the process. And I guess one final comment and I'll stop. I think one of the reasons that, it's kind of an uphill battle to do this is most people who are in behavioral health don't do any advocacy. They don't do any advocacy at the national level. They don't do any advocacy at the state level. They don't do any advocacy at the county level. It just isn't something that was part of the training and the culture of these fields as people came into the fields. And so I think part of changing this is also going to be changing the culture of the field and changing some of the training that people actually experience as they go through and get their various levels of their degrees. So let me stop there and turn it over to Deb, who will have a much better answer than I.
Well, I don't have the historical answer, but what I do find is that I speak to a lot of social workers who are clinicians who work with patients, and they're busy. You're working nonstop to treat your patients. You don't have time to think through what is my policy ask. And so part of that's on us. We have to make the data more accessible and clearer and make the policy ask clearer so that it's not a huge lift for someone who is practicing in the field, because as we demonstrated, you're not getting reimbursed enough. You're not able to provide all of the supports and services that you are actually allowed to deliver because of limitations in statute and for what you can get reimbursed for. So to make policy advocacy a little bit easier for anyone to be involved in, that comes down to a lot of the people higher up. And I think part of it also comes from the government, who puts out these rules and regulations, from CMS, that puts out these rules. They don't get to the people who should be responding to them. They get to lawyers and lobbyists, but the people who need to be responding are the people who have the on the ground experience. And that's actually who they want to hear from. They ask specific questions in these rules, like, what are the barriers you face when treating patients with substance use disorders? And the people who respond are not the people who treat people with substance use disorders, but no one's going to read through a 2,000-page rule to see where their name comes up, to see what they have to respond to. So I think there are a lot of systemic problems that prevent people from engaging as effectively as they could. And so as a social work profession, we need to figure out how best to hone in on what those important requests for information are and what our asks are to respond to them, and publicize it, make it so that people have access to this information, just in the way that you have done with this webinar here, and sharing it more broadly with your social work peers.
Yes, these are excellent points, and I really like the fact that you are mentioning there are like small things that social workers who are busy can do, like subscribing to these organizations and then submitting the send button to their representatives, but also the importance of having a more organized front with the profession. I also want to highlight the fact that we have organizations like CSWE and NASWE that are organizations that do promote specific policy changes. And NASW is the official social work organization that is responsible for making advocacy, to supporting advocacy. So I think that it's also important as social workers in the changing culture, right, for us to request that, because these types of organizations can advocate for what we need, so that we can have more of the time to make big, large-scale change. So that is fantastic. There is another question here. I am curious about the speaker's response to the case study shared on how best to address these. I'm not sure. I think that the question is stopped here. I'm not really sure if there's any more. To Deja, who is posting those for me. I'll skip that for now. See if you can finish the request, or whoever posted that, maybe repost. One question that I had right now, and this is for you, Deb. What are the biggest challenges right now to address these challenges that you mentioned with Medicaid? What is the opposition to these changes?
Yeah, it's a great question. I think one of the biggest challenges we always face in advocating for policy change is the cost. You may have been following, we're a little overspent in our country. There are debt ceiling conversations. So when Congress members are looking at new policies, they're worried about the cost. And the problem with how we look at costs when we're passing legislation is that they rarely take into account the cost offsets. So they're looking at how much it would cost to increase the reimbursement rate or to add new services, but they're not actually looking at how much money would we save if we actually provided, better prevention, harm reduction services. And that is something that we can work on. So we at the Legal Action Center partnered with health economists to look at what would actually be the cost of adding some of the services we propose, and what would be the cost offsets, both from preventing like unnecessary hospitalizations and overdoses, but also from the comorbid medical conditions. As Ron said, these aren't operating in a silo. It goes both ways. If you have a substance use disorder, you're more likely to develop certain conditions like liver failure, but other conditions can also exacerbate your substance use disorder. And there are a myriad of conditions that fall into that category. Depression is one of them. Hypertension is another. There's a high correlation with dementia. But we looked at a number of them that are specifically caused by substance use disorder. So we could demonstrate that actually treating substance use disorder would alleviate some of the costs associated with treating these other conditions. And we were able to demonstrate that while the cost associated with adding residential treatment, licensed and certified counselors, and intensive outpatient treatment would be about 1.7 billion, which sounds scary, the cost offsets were 1.4 billion. So we were talking about adding about $300 million, which is 0.04% of Medicare's budget. It is a drop in the bucket for how many lives we are saving and how many people we are helping, and well within the realm of something Congress can spend money on. But again, historically, we haven't been very good at taking into account these cost offsets. And so having the research is one of the things that helps, but making sure that the research is taken into account will help us to demonstrate that the cost isn't really a concern here when we actually are preventing additional costs down the line.
Thank you for that. I think that really helps illuminate some of what are the challenges that we have to face. And yeah, it's amazing to me because when I was in the Hill, I learned that $1 million is a rounding error many times in those budgets. And we kind of don't realize that. And it's really important to come into these advocacy strategies, having all the arguments, including the research and the stories, so that we can be effective in the advocacy effort. Ron, you had mentioned the importance of integrated substance use disorder treatment services, and you mentioned many collaboration with different professional groups. So what is the role that social workers have been playing currently within the integrated substance use disorder treatment model?
Oh, it's a very good question. And I again have students this very semester who are working on that problem. And there's a very special role for social workers in integrated care. And that special role is actually bringing what's called social care into that nexus, so that it isn't simply about treatment of the disorder or the related disorders. It's also about what do I need to do to get that person linked back into a social network, linked back into a job, linked back into housing, et cetera, addressing the social and physical determinants of health that played a huge role in that person's life originally, and so on. Now, I will argue that role is probably going to continue and grow dramatically over time as people have a greater recognition of the importance of the social and physical determinants. And we need to be helping people in the health field understand that by doing that, to Deb's point, you will reduce other costs. If you don't pay attention to those things, I would argue a lot of the money you spend on healthcare literally goes down the drain because it doesn't have any effectiveness. You aren't getting to the fundamental issues that lead to the problem in the first place. And especially if the person has the problem and they're trying to recover from it, you absolutely have to help them get re-engaged in the community. So there is a definite role for social workers in integrated care. And that role is being evolved as we speak right now. I want to comment on one thing that Deb said about Medicare. So Deb said that a very important part of changing Medicare is to bring parity to Medicare. President Biden, in his 2023 budget proposal and in his 2024 budget proposal, proposes to bring parity to Medicare. And he's actually produced a budget to go along with that and a strategy. We need to help him do some of those things. Part of advocacy here is saying, where's the president on this? Is the president supportive of this? He is. How do we help him get that over the line? Exactly what Deb was talking about here, and bring parity to Medicare where it's never had any parity in the past. That simple thing, the opportunity is out there literally as we are sitting here today. And if we don't become organized and take action on this, you know, the opportunity will come and go, and we'll be sitting here a year from now and there still won't be parity in Medicare. So strong encouragement for people to pursue that particular recommendation.
So in other words, don't be shy, reach out,
Exactly.
speak up, advocate for your profession and advocate for your clients. We have another note here. As important as it is to mention the profound, is this the one that I am? No, there's one here before. This is probably the most clear information I've received about the issue paired with how to take action and meaningfully advocate. I would love to pass on this information to community members. Do you have any advice on how to encourage them to take action if they are fearful of acting against something? Thank you.
So
It's a great question.
yeah, Deb, go ahead.
Yeah, so I would say one of the awesome things about being part of a profession like social work is you have like the NASW, you have national associations, and they also have state associations, and NASW and its state affiliates host advocacy days. So do it with friends, do it with your community members. Not going alone is one of the easiest ways to like get over that first hurdle. And you just sign up and they give you all the talking points. It's actually quite fun. So when I am encouraging people to get into advocacy, I think that's a great first step, and it helps rip off the Band-Aid and you see how easy it is. When you go to meetings with people, sometimes you're meeting with the legislator and that's really cool. But often you're meeting with one of their staff members, and their staff member is probably like a 25-year-old who again, like wants to make a difference. So they're usually excited to meet with people and to hear from you. And once you do it the first time and you see that you're talking to a human just like you who wants to learn about the issue from someone with the expertise and experience that you have, you see that it's kind of fun. So that I would say is like one of the best ways, get involved with advocacy days. The other one, again, similarly, ripping off the Band-Aid, is signing up for the types of like action alerts where you are told exactly what to say, because you get a script, you call, you have your 30-second pitch, they say thank you, you hang up. Like, again, advocating does not have to be like standing up and testifying before all of Congress. You should do that too, that's really important. But in the meantime, it's each of those like little nudges along the way that push people to change their minds. And one of the best advice I ever received from one of my mentors in the field was that advocacy isn't just about changing laws, it's about changing minds. Because we have to fundamentally change people's minds that this needs to be part of healthcare, that it needs to be part of our system. We have to change the systems, right? So we have to actually change their minds first. So if you can be a part of changing their minds to let them know that social workers deserve equitable pay, that they deserve to be like on par with all of the other medical professionals, that what you're doing on a macro level when you're engaging in the community, that matters too, and that should be reimbursed at a real rate. These are all things that you can do to help change folks' minds. And I see another question that I also want to address, which is related. You know, how do we talk about structural racism in a way that targets the systems that create and perpetuate this instead of those impacted by it? Talking about racism. That is like one of the first things you have to do. And racism is baked into our healthcare system, right? Because we started with like all the studies against people, or, you know, research against people, and how most treatment is even built into, you know, studies that were only tested on white people. So treatment isn't necessarily designed for everyone. We have so many problems in our system. By talking about it, by raising these issues, that is the first most important step. And then the second step is understanding the disparities and seeing where they play out. So for example, in Medicare, we see that a lot more Black and brown folks are enrolling in Medicare Advantage plans, these plans that are managed by private insurance companies. One of the reasons that happens is because of historic discrimination and poverty, which has led these folks to be more interested in plans where they're offered certain things. So Medicare Advantage plans can offer you some cost sharing assistance. They might offer you a gym membership, things that are really appealing if you're struggling with your finances. But Medicare Advantage plans restrict your network further and make it so that it's harder to access care, because they can impose more of those utilization management practices like prior authorizations. So we need to identify where the disparities are so that we can actually make sure that that's where we're targeting solutions. So we know in our field, we're targeting a lot of effort into fixing Medicare Advantage because we know that that's where there are a lot of structural inequities that are exacerbating access to care for Black and Brown individuals who are enrolling in these plans at a higher rate. So it's research, it's talking about it, and then it's targeting your policy solutions to actually fix those systems.
Ron, any other thoughts as we close?
Well, on the final issue that Deb was talking about, so Deb was talking about advocacy around structural and interpersonal racism. There also is needed work in the community to deconstruct the power systems that keep racism in place. And it's all about power in different domains, power in education, power in finance, power in religion, and so on. You have to deconstruct those systems that are keeping racism in place. Social workers are very well trained to do that kind of work. And I have many students at USC who work on racism, and they work on structural racism by trying to understand the power dynamics and then go in and actually change the power dynamics in those communities. So I encourage people to become engaged in that side of it as well. We need both sides. We need the advocacy side, and we need to deconstruct racism as it exists in our communities.
Absolutely. Well, thank you so much for such a wonderful, thoughtful discussion. Thank you all for attending, and we look forward to continuing the conversation next month on June 21st with Dr. Nalini Nagy on social work, substance use disorder research. Do we have any final things we need to share from the CSWE end?
Yes, we do.
Go for it.
CEU information and handouts will be available, and quiz will be available within 24 hours. And also the webinar will be uploaded in 24 hours. So look out for that information on the Learning Academy website.
Wonderful. Well, thanks everyone. Enjoy the rest of your evening. And if you have any questions later on, feel free to send me an email.
Okay, very
Bye.
good. Take
Thank
care.
you.